TopMedTalk. Hi folks, well, welcome back. It's Monty Mythen here, Editor-in-Chief of TopMedTalk, live from the ANZCA ASM 2023. So I'm here in Sydney, Australia, as a guest of the Australia-New Zealand College of Anaesthetists and the Faculty of Pain Medicine. Lucky enough to be here on a beautiful stand that they've made available for us, dressed up as TopMedTalk all over it, combined with Be Connected, the name of the meeting. We have some unconditional grant support from 3M via the college. They're on booth 79, which is right next to us. So lucky enough to be joined by two guests who I'm going to introduce sequentially, starting with Dr. Tracey Tay. Tracey, welcome.
Thanks very much, Monty. I've been an anaesthetist for almost 30 years now, but recently moved into a new role as the National Medical Advisor for a large private healthcare organisation. But right from sort of day one of my specialist work, I've been concerned about the wellbeing of anaesthetists, and so I was always curious about what already existed to support doctors, and attempted, usually ill-fated, approaches at organising support. But then I came across the, used to be called the Welfare of Anaesthetists group, which was set up by two amazing women, Genevieve Goulding and Di Cassandi, some time before, who were incredibly open about their own personal struggles with poor mental health. And they had established the Welfare of Anaesthetists group, which aimed initially just to raise awareness, but over time has played a bigger and bigger role in supporting good mental health and wellbeing for anaesthetists, to the point where it became an examinable subject for anaesthetists. And I was one of the chairs of the group for some time, but I got a bit cross after doing this work for about 10 years and felt that what we were doing mostly was raising awareness. And people would come along to the sessions and leave without a place to go or something to do. So it almost felt as though we were exploiting people's bad experiences. So I felt strongly that we needed to pull in the sort of theory of change, project management, all this sort of boring stuff that doesn't usually play part of what anaesthetists do. But I had been playing that field, and try to pull together all those who were interested and create a framework of action that we could follow. Because there were lots of great bits. There was mentoring over here, and there was a bit of peer support over here, guidelines, all sorts of things happening, but they weren't coordinated, and nor were they being evaluated. So a lot of effort, energy, dollars being put into all these initiatives, and no real sense whether they'd made any difference at all. So that's where I'd come from, and always wanting to learn, always wanting to meet people who were also interested. And in the process of that, met Dr. Jo Sinclair here. So I might pass over to Jo to tell her story.
Thank you, Tracey. Welcome, Jo. Tell us a little bit about yourself first, if you could.
Yeah, sure. I'm an anaesthetist at Te Whatu Ora Counties Manukau in Auckland, and currently one of the co-chairs of the Wellbeing Special Interest Group. I have also had a career-long interest in this issue of doctors' health, initially through what I learnt in anaesthetics, but a growing awareness that it's not just anaesthetists that it affects, and then also it's not just doctors that it affects as well. So I've had a role in my hospital as a clinical lead for employee wellbeing for about 3 years, and then from October of this year moved into an interim role with our new healthcare system in New Zealand that we're trying to develop, and advocated for them to create a separate wellbeing stream for setting up a dedicated resource for an infrastructure for addressing all the issues with wellbeing that are affecting all our staff in the healthcare sector at the moment. Really similar to Tracey, that experience of wellbeing activities being lots of awareness raising and not a lot of action.
Yes.
And that's kind of driven me through my, progression from being a wellbeing advocate just within my department to then looking at the hospital, if I can't get the answers I want from within my department, maybe if I work at an organisational level, that'll help. And then now I've gone national to try and get some action. And hoping that I'm not going to get to the end of the line and still find we're not having action. But I think we're making some progress.
So we, over the years on TopMedTalk, have had a number of conversations about burnout. And they were interesting conversations, awareness conversations, as you say, prior to COVID-19, the C word. And amidst the COVID-19 thing, I think the reason that everyone's much more forward coming in talking about burnout now is because almost everyone's experienced it, possibly for the first time for some people who thought they were extremely robust. They've joined other colleagues in a world of anxiety and depression and exhaustion. Is that a fair comment, Tracey? Is it
absolutely
a sad way of helping to bring this forward?
It's very true. I think the other part, as well as more individuals experiencing it and understanding, is that it has had impact on organisations and their performance.
Yes.
And I know Joe's really working hard on that. But I think the Americans have done that better. They've looked at the link between burnout, turnover of staff, lower productivity, increased costs, and more importantly, worse outcomes for patients. So that triangulation has been really important, but certainly in Australia that hasn't, until COVID, I think it was less believed and probably not even measured really. So, but now after COVID, we have significant workforce challenges like everyone does in the world. And so people, or organisations at an organisational level, the powers that be saying, well, we'd actually better pay attention to this if we want people to attract staff and we want to be able to retain staff and have them work at the top of their scope. So,
in previous conversations, we reflected on the fact that historically, as clinicians, we've sort of, I don't know if we felt or we've inherited this sort of sense of need to have a facade of robustness. And there's nothing wrong with me, there's just other people who get sick. And that if one was sharing the fact that one had challenges in life, that was a sign of weakness, which isn't where we went. And we've quite often used the term machismo, which you recognise is very male, but perhaps was driven by some of our male forefathers. Do you think we've all changed now?
It is changing. It's definitely changing. You probably weren't able to get to a session we held yesterday, but it was about getting back to work after a significant life event.
Yes.
And our first speaker spoke very openly about fentanyl addiction and his pathway back. Could have heard a pin drop. And I could not imagine that conversation 5 years ago, really. So I think the other thing is that in terms of the machismo is that we've actually got a lot of men now speaking out, whereas before it what seemed to be the up to women to speak about it and seemed to be more acceptable. And the other thing is that I think we've managed to subjugate our imposter syndrome a bit and move up the ranks in terms of our seniority, you make use of your grey hair and your position. And when you can show some vulnerability, people go, oh, it's okay. Like, they still make it to their senior jobs. It hasn't held them back being vulnerable. So, although Joe, I'm sure you've got something to say about that.
Yeah,
too.
I don't think medicine has valued stoicism. As a trade, we talk about our work ethic. We don't talk about in performance in sports. High performance sports, they schedule in their rest. They have a rest ethic as well as a work ethic. We only talk about our work ethic. We don't value that sort of rest and recovery period. We are, as you said, we see ourselves as the caregivers, not the people that will even need to receive care. And so we haven't traditionally talked about it. I've tried to always walk the talk in that respect and be quite open about my own journey along the way and experience of burnout and that kind of thing. And I think that's what we need, is that role modelling from senior people, that it's okay to not be okay sometimes, and that everyone goes through that. And that's a lot of the stuff that I'm doing within my organisation is just initiatives that try and encourage connection and talking and try and reduce some of that stigma around having issues along the way in our careers, because I think everyone does. It's just that we don't talk about it.
So, Joe, we talked about moving from the sort of awareness discussions, which are predate COVID, and I think we're all recognising the fact that we're freer speaking about this now. What about some tangible examples of doing something about it?
Yeah, there's not as many as I would like there to be, but they're coming. I mean, I think Tracey referred to a framework, so she was instrumental in organising the development of our Long Lives, Healthy Workplaces toolkit, which gave people a framework for...
Say that again more slowly, Joe.
Long Lives, Healthy Workplaces.
Lovely.
So it's freely accessible through the Australian Society of Anaesthetists website if people want to go and have more of a look at that. But that was developed with Every Mind, which is a mental health organisation in Australia, and it gives people some ideas around assessing need and then taking some action. And I often end up talking to people about trying to bring it back to small things that you can do, because if you look at the big beast of a problem within healthcare of global staff shortages, burnout rates, that kind of thing, it feels quite overwhelming depending on what level you're in. But actually there's a lot of small things that we can do. In COVID, we started talking a bit about that Maslow's hierarchy of needs, and the things on the bottom are just sometimes quite simple things that we can do to make work life better for people. Just the way that we treat each other, connecting with each other, making sure that people have got decent food, somewhere to sleep on nights if they get the opportunity to, access to water. Those kind of things came up a lot more in COVID, and we talked about them a lot more. And so I often end up talking to people about that, those circles of control and circles of influence, and just the fact that you can start with something quite small and it does have ripple effects. And also that idea of that sort of aggregate of marginal gains with the British cycling team, the 1% things, they do all add up. But we just, if we're all doing something that makes a little 1% difference, it's going to make quite a change.
So our leadership back in London, when we were starting to really feel burnout at University College London hospitals, I think did a very refreshing exercise where they took the trouble with some external help to get bandwidth, to try and ask everybody what could help. And it was an enormous eclectic list. For some people it was, I have to reliably pick the kids up from school on Tuesday and Thursday. Okay, let's make that happen. There's nowhere for me to park my bike. Is that fair, Tracey? It's often very, very simple.
Absolutely.
You've just got to listen, and it's not one fix. It's not give everyone a box of chocolates.
No. And it's it's touching that people do think that the bowl of fruit is the place to start, and there's nothing wrong with that, and there's nothing wrong with mindfulness sessions and yoga sessions and all of those things. All great, but it does start with listening to what people need. It's often very simple things that can fix. And what was I going to say there? But the other thing that I think it is the process of listening actually makes people feel valued. So that you asked people what they needed. Probably
or my leaders.
Oh, your leaders.
Wasn't me. I was admiring their wisdom of doing it.
Yeah, it just that someone stopped to ask what would make the difference is.
And then seeing some action as well.
Of course. Yes.
Very helpful, yeah.
Now, one new challenge we have mixed in with all of that, we do have a global manpower crisis that we've have seen, and we've all taken a time to pause on the quality of our life, and maybe we've retired early, maybe we've remodified our work patterns. Now we don't have enough people to do the work. How do we strike a balance? Because now everyone's keen to not work on Fridays and Mondays, and everyone wants the weekend off, and no one wants to do nights. So how do we get that bit right?
It's a challenge. It's a challenge.
Is that a fair summary, though?
It's absolutely
it is.
Fair. Yeah. I have, in my new role, so it's a national role, and my organisation has hospitals, public, private, and a lot of aged care facilities as well. And we look after home care, we have virtual care. So that challenge is incredibly broad. And I feel there's a crisis for society. I think my advice has been to everyone, stay well, start looking at preventative health care. And as a society, we're going to have to do that. In the meantime, I was talking to another colleague, and they had massive shortages in the hospital of doctors. And the Director of Medical Services has taken this really interesting approach and has gone from having something like 20-odd FTE down vacancies to full staffing. And what he did, similar, he asked people what they wanted, and he found that by offering things like part-time work, job sharing, quite interesting shortened hours, like 9 till 3, he now has no vacancies.
Yes.
This is just in Perth. And a very happy workforce, and it has worked out. So the people who were staying home because they were burnt out, but also because they could not get a job that fit their life, have come back.
Yeah.
So it's uncovered that other workforce that's out there, but usual workplaces don't allow them to come back to work. So I think it goes back to hearing what people need, but I also think it's a crisis for society as well, so for healthcare generally.
Jo would...
Yeah, I was just thinking as you were speaking, there's another piece in there which is around how well we support our leaders in healthcare,
Yes.
and how we support them and educate them to have those kind of conversations, those what matters to you kind of conversations, and finding the pebbles in the shoes and and doing something to fix those, because not some of our healthcare leaders kind of are the last person to step backwards when they're looking for someone. So they're not all there because they really love, leadership, and they're not all there because they're all people persons or whatever. So, I think sometimes we need to put a bit more effort into that to help our leaders understand those kind of concepts and to help them be well in their roles as well.
I say, who looks after them?
Yeah.
Because it gets lonelier and lonelier.
It does.
As you get closer to what we refer to as the top.
Yeah.
But everyone needs looking after.
For sure.
How do you do that in your organisation, Tracey?
Sorry?
You've got a much more senior role in your organisation. If you're prepared to share, how do you look after the people at the top?
I've had this saying for some time, because the people I admired or who were in senior roles to me, I used to say, I don't think you're modelling a job that anyone wants.
Yes.
And I think I looked at my senior people, and they were always tired, always looked tired. They were always available, open door. I'm going, I don't know if I want that job. I don't know if I want to be there. And so I try to role model those things. And I also chair the diversity and inclusion strategy for my organisation. So there's loads of opportunities to be vulnerable and open, and So I'm grateful for that opportunity, because I think that not everyone can do that. There's so it's, the onus is on us as leaders to role model that.
So, Jo, as we get close to the end here, any signposting for people, any resources that are out there to help us, any places we should be looking?
I mean, we've mentioned the toolkit, which is a great resource. The ANZCA Wellbeing Library Guide is a really good collection of everything we could think of relevant to wellbeing, and that's accessible without having to log into the system, so anyone can get hold of that. But there's a great critical incident support resource in there that's recently been developed with Liz Crow, that critical incident debriefing comes up a lot in wellbeing circles as an area of need that we don't do well yet. So that's all there. Lots of videos. There's so many podcasts out there now that are fantastic.
There's only one TopMed Talk.
There's only one TopMed Talks, though. Yes, there is. yeah, there's certainly becoming a lot more about it. It's a topic of conversation in much broader circles now than it used to be. So it feels quite easy. We've also had Cherie Johnson at this talk, who's written an amazing book, The Thriving Doctor, which I feel like is a distillation of everything I've learned in about 15 years of thinking about this, and all in one book. So if you want to jump 15 years, that's an amazing source for insight into how doctors tick. She's a psychologist who coaches doctors. So yeah.
Tracey, any particular signposting? Anything you recommend?
Look, I think Joe's all across it. The other great thing is that we have resources for both Australia and New Zealand, and there are some differences. Obviously, online world you can access both, but there are some particular resources that are country specific, so worthwhile looking there.
Well, thank you both for sitting down and sharing today. Thank you once again to ANZCA for supporting us, and for 3M for their sponsorship, and to our other sponsors, and in particular Edwards Life Sciences, GE Healthcare and Medtronic. Without your generous sponsorship, we wouldn't be able to keep this as free, completely free, open access medical education for the world. Thanks everyone. See you again soon.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.